much for the kind invitation. My talk will be on avoiding radiation and the impact on patients and healthcare personnel. These are my relevant disclosures. In the next 15 minutes, I will speak about the different definitions in terms of ionizing radiation and how we measure that, the exposure related to different imaging techniques, the risks associated with these exposures, and then the adjunctive benefits to a no fluoro technique such as no lead, and my personal exposure reduction. I want to start by showing pictures of two of my colleagues. On the left is an electrophysiologist, Dr. Bill Kaveen. On the right is an interventional cardiologist, Dr. Mark Satskis. They both recruited me from Mass General to join Pacific Heart in 2004. And within a short period of time, both of them died of radiation-related cancer. Mark on the right had a glioblastoma on the left side of his brain. He was 52 years old. And within a year, Bill on the left developed refractory multiple myeloma. And a third physician a few years later developed a left-sided glioblastoma also in our interventional lab. So this really hit home in terms of the potential risks of ionizing radiation. It led to my search of techniques and technology over a decade ago, looking to reduce our radiation exposure. So when we look at the harmful effects of ionizing radiation, we want to look at this in relation to patients, to staff, and to physicians. When we look at radiation effects, there are basically two types of biological effects resulting from radiation exposure. There's a stochastic injury or cancer induction due to misrepair or damage of DNA of a single cell resulting in genetic transformation. And this likelihood will increase with the total amount of radiation absorbed and is greater in young adults as they will live longer and more likely to develop cancer. This is in contrast to deterministic injuries, which are due to reproductive sterilization of cells. So these are not expressed clinically until cells unsuccessfully attempt division or differentiation. So for example, skin, subcutaneous fat, muscle, these can be severe and devastating, and for patients can lead to years of pain, multiple surgical procedures, and permanent disfigurement. Now, in obese patients, there's a higher risk of radiation-induced skin injury, primarily because the absorbed dose at the entrance site in obese patients is often 10 times higher than in non-obese patients. If we look at medical history factors, disorders that affect the ability for DNA repair genes to function, such as familial polyposis, hereditary malignant melanoma, these all increase radiation sensitivity. And autoimmune and connective disorders, along with hyperthyroidism and diabetes, are also associated with increased radiation sensitivity. So it's important to keep this in mind when you have patients with this history undergoing procedures. This finding is consistent when we look at other papers looking at the radiation exposure to patients. And this is looking at the dose area product, which is grays in centimeters squared, of patients who are less than 25 in terms of their BMI versus patients over 30. And you see almost a threefold increase in total DAP in the same patients using the same amount of fluoroscopy and fluoro time and same techniques. We'll compare that to someone who's lower BMI, so a dramatic increase in these obese patients. And this correlates to an increased lifetime cancer risk. So if you look at a BMI of less than 25, looking at millisieverts effective dose of 15 versus over 30, it's almost 3 times that. The cancer incidence changes from 1 in 1,000 to 1 in 400. So there's a dramatic difference for these patients. What about the radiation exposure to staff and physicians? And a lot of this data really started looking at the solid cancer rate in atomic bomb survivors. And what we saw is there was a significant radiation dose response to nervous system tumors and brain cancer. And we've seen multiple reports of an increase in incidence of brain cancer in interventional cardiologists, in radiologists, which would also apply to electrophysiologists. And there's no question that these physicians are at increased risk of brain cancer, particularly glioblastoma. And when you break this down in terms of specialty, interventional cardiologists, electrophysiologists, and radiologists have the highest rate of these cancers relative to other specialties such as rheumatology, for which they've been compared. What about the less obvious but now more logical complications, which are orthopedic complications? If you think about wearing a 5 kilogram lead for hours and upon hours a day for years, there's no question that there's a significant increase in spine problems compared to, an interventionalist, compared to other specialties. But it's not just spine. There's hip, knee, ankle, and if you query your friends around the room there or in your practice, those who have been doing procedures wearing lead for decades, the majority of them will have some sort of orthopedic complaint or injury and may require procedures for this. So this is something that's often not thought of, but is extremely relevant in terms of prevalence in physicians doing radiographic procedures. And if you look at the different types of radiation doses, and you look at this graph, you see that eating a banana gives you about 0.25 millirems on an annual basis. And this is probably the most common source of background radiation for humans living on this planet, is from radiolabeled potassium, which is naturally occurring, found in bananas. And you compare that to what a single transatlantic flight is versus a mammogram or radiographic procedure would be even higher. Patients then tend to understand the relevance of this much exposure for a given procedure. And while for a patient it may be one or two in their lifetime, for physicians, you're looking at it day after day after day. And if you look at the effective dose in millisieverts, and you look at a chest x-ray, which is 0.025 relative to coronary angiography or an EP study, which would be probably 15, you see what an astronomical number that is per case. Multiply that over years. So when we look at radiation dose, I think it's important to understand a few definitions here which are more relevant, especially when you're discussing this with a patient or even among your colleagues. And an important term to understand is what's called BERT, or background equivalent radiation time. And what this is a comparison of the natural background radiation, which totals to about 3 millisieverts per year, relative to a given procedure. So for a patient, it's much more understandable knowing that the background radiation is 3 millisieverts, and for this one procedure, it may be 50 to 60 millisieverts, or even more if it's a case where you use more fluoroscopy. Versus critical organ dose, which is just a radiation delivered to an individual critical organ, and the surface absorbed dose, which is radiation delivered to the skin surface. The most relevant definition is what we call DAP, or dose area product. And dose area product really represents the exposure of a patient to radiation at the skin entrance in square centimeters, multiplied by the radiation dose at the surface. So it's valuable because the radiation-induced bioeffects are directly related to both the magnitude of the radiation dose and the total amount of tissue that's irradiated. And many fluoroscopy and new angiography units will give you a dose area product reading at the end of every case, so you can understand what the exposure rate has been. So if you look at that and you compare what a dose area product, or DAP, is for a CT, anywhere from 40 to 60 gray centimeters squared, versus coronary angiography, which is 30 to 47, versus an electrophysiology procedure, you will see that these procedures can vary between 20 and 50 or 60 gray centimeters squared, or DAP, for a given case, and maybe even more when you step on fluoroscopy, even longer in an obese patient. So if we recognize the cumulative effects of radiation and how much we are exposing ourselves day after day doing these procedures, why don't we all focus on fluoroscopy reduction? Is it that we haven't thought about it? Is it that we didn't think it was that important? And is it important to eliminate fluoro altogether, or is it good enough that we can do what's called a LAHRA, or as low as reasonably achievable? So is there a value of going from 50 gray centimeters squared of DAP down to 5? Fluoro time from 20 minutes down to less than 1 minute. And all of that is relevant because of your cumulative radiation exposure, and ionizing radiation will decrease significantly. And I think the tools that have really helped us include catheter visualization, 3D mapping, and ultrasound technologies. And with these technologies, all of this is very achievable. And I'll show you kind of how we achieved it at my center, obviously based on the motivation of my colleagues that had cancer. So the first question we have to understand is, why do we rely on fluoroscopy? Is it because we need to have some comfort believing where the catheter is? So many people will step on fluoro just to kind of see where their catheter is in kind of this fluoroscopic background where you really can't identify soft tissue well and you can see the bones. Another reason people step on fluoroscopy is they don't have a comfort or a sense where the catheter is going when they deflect, so they have to watch on fluoro and see which way it's going. when they initiate movement of the catheter, knowing that the complex mapping systems now can direct you exactly which way the catheter is going to deflect when you deflect it. And finally, there has to be some sort of understanding or trust in the mapping system and the ultrasound system by the operator, which comes with experience, so they realize that the resolution of these systems is even greater than that of fluoroscopy. And here's an example of fluoroscopy. You see the spine, you see your catheters are on one side of the spine. You assume that's in the heart. You really can't tell the chamber. There's not much really here for us information to glean besides that. So if you think about fluoro reduction and where you can get to, this is an example of where I started in 2009, where my fluoro times were about 30 minutes. And I challenged myself to drop my fluoro time. And the first thing I did was move the pedal away so it wasn't in reach. And I started using adjuvant technology, and you can see how the fluoro times dropped significantly. And it was these alternative imaging sources. Here you see in 2011, here's an ICE catheter in the coronary sinus, which was my main view, and you'd see the left atrial appendage. You'd also see the right upper pulmonary vein, the right lower pulmonary vein, the left pulmonary veins, all within one view. So it was using the combination of these types of ICE technologies and 3D mapping that allowed me to feel more comfortable. And if you look at my first 100 cases in 2010, the median fluoro time was 0.1 minutes with a median procedure time of 162 and a median lead time of 12 minutes. That is, after 12 minutes after I'd done the transeptal, I basically took off my lead, put it next to me, and was not wearing lead for the case. And so that really got me thinking about the concept of how this is achievable for every operator. And this is an example of how we developed a technique of how to do a fluoroless transeptal. Here's your SVC view from the right atrium. Next, you can see your guide wire from the groin going up the SVC. Okay, this is all from, if you look at the data of this is going back to 2011. And then you can advance your sheath directly into the SVC with the dilator. And that's not all. Once you get into the SVC, you basically change your view. You pull your needle dilator system back, and then you can identify with ICE exactly when you're in the septum. Here's the left pulmonary vein to know when to puncture. So these are techniques well over a decade ago, which is how I really took that next step of going to no fluoro, was then understanding how to image from the groin and do a transeptal without fluoro. So was that a big deal, getting 1 or 2 minutes of fluoro time off? Perhaps, but I think the bigger deal was not having to wear lead for the rest of the case. And while this was a decade ago, something more recent, this is an example of a no fluoro case for a Summit VT PVC. And you can see here I have the intracardiac ultrasound catheter retrograde aortic looking at the left coronary cusp and the left main. And you can see that here in this video where we're basically seeing Doppler, and then we're actually drawing the left main right here in the left coronary cusp, so I could create this anatomy without using fluoroscopy, without moving my catheter into the left coronary. And if you look beyond that, you can see the map where you see the anterior intraventricular vein, the AIV, the RVOT, the left coronary cusp, and this was that left main that we drew on the map, again, all without fluoro, but using more modern technology relative to the standard ICE that we had used before. So all of these things are available. So let's look over the last 10 years, the impact this has had. So if you think about the average of, let's say, for me, 125 AF ablations a year, if I was doing a low normal DAP, it would be 50 grays per centimeter squared for the procedure. Multiply that per year for 125 cases. Let's say I dropped that down to 40, then that would yield about 5,000 gray per centimeter squared. But over 10 years, that would be 50,000 grays per centimeter squared that I was exposing myself to. So for me, for the last 10 years, I have not used fluoroscopy for ablation. So that's zero ionizing radiation. That could have easily been 50,000 or more. More importantly, I've also had no lead or orthopedic issues. And if you multiply 5 kilograms times 3 hours per case times 125 cases a year times 10 years, that's 18,750 kilogram hours. Now, will this reduce my risk of cancer? I certainly hope so, with a significant reduction in radiation, but definitely less back pain and fatigue. So, my message is that these harmful effects of radiation on physicians has been significantly underappreciated, and technology does allow for greater efficacy and safety versus fluoro-based procedures. And I think this is readily achievable. In the next few lectures, you're going to hear about certain techniques that can help you get to that level, please be careful using fluoroscopy. Thank you very much.